Okay, this is just, as I think I answered a question earlier today, about 2/3 of cases, I will open the neck and do a corset platysmoplasty. I won't really show that video because it's not terribly interesting. As you saw in the previous presentation, I used this transillumination method with the skin flap. I found it extremely important. When I first started to do this, I was finding that the Smas, especially this area right here, right at the zygomatic arch and right beneath it, it's simply thinner. And if I raised the skin flap, if I was sort of trying to move along quickly, and I laid the skin flap relatively parallel to the face, I put the scissors in, no matter, and then you tent up the points of the scissors and you just push your scissors forward and you spread. Even if you do it gently, even if you're pretty certain the tip of those scissors are tenting up appropriately, what I came to learn was that, as Dr. Cadell sort of poked fun at me when I was there in Santa Ana doing some cases with him, he said, you're bringing up 20% of the Smas with you. Maybe not comprehensively, but even if you do it in one or two areas, when you've raised that Smas flap, anybody who's tried to do it this high in the face, you don't have to turn the whole thing into a Swiss cheese before you have a bit of a technical problem. If in two critical areas you make it a little thin, when you put some traction on it, you'll get holes in it, and then much of the advantage of what you're attempting to do goes away. So we transilluminate like that, and here's a teeny video. There's nothing terribly special about this. It's a little laborious. When you get down about the level of the tragus and lower, you don't need to do this. Pushing scissors is perfectly adequate because the Smas is quite a bit meatier. So you can see, we get the light going, and every step you can see more light. And it seemed to me like a little bit of an esoteric exercise, but harsh experience simply shows that when I do this, I don't get the Swiss cheese Smas flap, and when I do it the old way, I do. Then I lift a long cervical skin flap. Here's fundamentally where the high Smas incision is. It's pretty geometric. Right here, we're right above the level of the zygomatic arch, and we come back fairly posteriorly. Again, nothing. Oh yes, this is me making that incision where you might be concerned about the frontal branch. We just make sure the tissue is tented up. I don't think you're ever going to get the temporal branch going over the zygomatic arch if you simply tent the tissue up, and there's 15 different ways to do that. You can see I've got these Alice clamps pulling it up. I'm not even sure that that's necessary. Okay, and then after we make that incision, where's my pointer? This is just me starting in the superior posterior corner and elevating the Smas. Anybody could do this. Okay, see what this video is. Oh, I see, more of the same, just continuing to elevate the high Smas component of the flap. And sort of that's then here a few minutes later. And then in the posterior inferior portion, again, I'll talk more about this extended platysmal component, but I don't know that I go 6 centimeters below the mandible, but I think I probably go 3.5 to 4 centimeters below the mandible routinely. This is just, obviously you're concerned about the marginal branch. Got to be cautious, make sure you have that layer of fascia down. I use this nasal speculum. Oops-a-daisy. I think I saw Wayne Larrabee do this once. He had a special instrument. I could never find it. I think I know why. But I went to the manufacturer. They said that we just sold them all to one guy. So I know. So here I use the poor man's equivalent. We have a long nasal speculum, and it works pretty darn well. And so, did they? I'll call them again. So I gently elevate the Smas. What I do is I turn that nasal speculum forward initially, and then I turn it straight inferior. So I'm 5 centimeters beneath the mandible, and then when I have that flap up completely, and I'm certain the nerve is not in there, I just cut it. Okay, and so here we go. This is just me showing, this is almost the full extent of the Smas flap in the high Smas incision. Elevated. We're not seeing the inferior component completely, but that's almost the entire flap. Here's this picture is meant to demonstrate where I'm elevating. When you look at the little dots versus the crosses is where I'm going to elevate the Smas flap in the deep plane up to the high Smas incision, whereas the dots are where I elevate the skin. Okay, that's me holding up the Smas flap. There is me laying it back down. Before I suspend, I cut this postauricular little tongue off and I bring that behind the ear, because when I bring it superiorly and posteriorly, obviously there's a little bit of excess, so I use it for that purpose. I find it works pretty well. I think if you just put some sutures back there and cut that thing off, it would probably work just about as well. But that's what I do with it. Okay, this is after the suspension sutures have been placed, horizontal 3/0 PDS. The only problem I've ever had with that, sometimes they're a little bit palpable for a couple of months over the mastoid, but no other problems other than that. Okay. Further details, again, I'm trying to be expeditious with this presentation. As Dr. Wong indicated, we need to move along, so I won't go too much into this. Ligamentous release, Dr. Giacono covered that really quite nicely. Optimized release of the skin. The idea is not just to clear the skin off the Smas all the way to the nasolabial fold. I like that sort of concavity beneath the convexity of the midface and leaving the skin coherently attached to the Smas about this level down, I think is very rational. Appropriate vectoring and mobilization of skin versus the Smas flap. So again, to emphasize this point, I think there is some artistic license here, okay? And the absolute emphasis in my practice is that these patients look natural, absolutely natural. I think that, I think if you leave the flap composite, okay, my impression in my own hands, I'm not speaking about anybody but my own hands, is if you leave the flap composite, the patients tend to have a slightly stylized look. I won't say that they're tight or anything like that, but they're slightly stylized, slightly stark. Whereas if you delaminate the skin from the Smas and you move the skin in a somewhat more horizontal vector, I find that the patients look natural. Sufficiently natural that, as I was just joking with somebody at the back, I think if I were hit on the side of the head with a brick and they wheeled me in, but I still sort of could do facial plastics, I looked at my own patients and I wasn't able to inspect behind their ears. My goal is I would have difficulty, tremendous difficulty telling who I've done a facelift on and not. That's my goal. Yes, and some other things that we're not going to mention much: ptotic submandibular glands, bulky anterior belly of the digastric. I do not routinely manipulate those structures, but I will do so when I need to. Platysmal transection was mentioned yesterday. Probably in about 5 or 7% of cases, I do a full transaction of the platysma. Okay, briefly, the extended platysmal component, that's the black line down there. We've heard a little bit about this before from other surgeons, so I won't perseverate on it. I think it does help in the anterior and lower neck. Advantages of the high Smas, low platysma facelift: same improvement. I'm talking about the platysmal component, same improvement in the midface and infraorbital areas, enhanced ability to restore the neck, including the inferior and anterior neck. Disadvantages: requires a little bit more time. Okay, some pictures. I showed this yesterday. This patient does not have fat. This is simply a high Smas, low platysma facelift. Nothing else. No eye work, nothing. Same person. I think she looks natural. I can't find any hint of lateral sweep. I hate lateral sweep. I hate Nike swish deformities. I hate it. And so I try not to get it. Chin down. Here's a nice lady. You could say that's a chip shot patient. She's skinny. She's got reasonable bone structure. 11 months post. This one had some fat transfer. I would say she doesn't look tremendously devolumized, but I elected in this patient to do fat transfer. Okay, chin down, better. Okay, so, and that's incision around the ears. Conclusions: I think the low cheek Smas flap, the low incision elevated below the zygomatic arch, is a fine incision and will get you a nice result in your jowls, a nice result in your neck. I favor, the deep plane approach. However, the results in the midface and the infraorbital region are not so hot, and perhaps that's why we've spent a decade listening to people talk about endoscopic mid-face lifts and a great deal of discussion about fat, especially in the upper cheek. Planting the flap higher along the superior border of the zygomatic arch allows a simultaneous lift of the jawline, cheek, midface in a single unified flap. Incorporating an extended platysmal extension and suspension permits a more comprehensive and durable rejuvenation of the lower and medial neck. Conclusions, furthermore, is the argument to pursue a high Smas, low platysma approach to facelifting compelling? Well, I guess it depends on your perspective. It does take a bit more time, I think. Right? Raising that skin flap up there just takes me a little bit more time. Raising the Smas, it's a thin flap. You can buttonhole it and then you're disappointed. And so it does take a little bit more time. What I would tell you is this: in patients where I see more cheek descent, I don't always do a high Smas facelift. But when I clearly see that there's deficiency there, I lean heavily towards it. If I see that there's not much deficiency in that area, I sometimes defer to a more sort of, you could say, conventional location to incise the Smas. Thank you very much for your attention.